All right, assalamu alaikum, everybody. So we're going to be talking about the liver now. We're going to be talking, a little bit of introduction and injury patterns of the liver, starting with a little bit about the normal weight and the location of the liver. So weight about 1.5 kilo, residing in the right upper quadrant, receiving about 25% of the blood supply of the body. Now, out of this 25%, about 70% of it is portal blood, and about 30% is actually a hepatic arterial blood. And the two bloods actually mixes in the hepatic sinusoids. Now, as a result of that, infarction of the liver is rare because it has this dual blood supply, similar in a way to what you see in the lung.
Because the liver comes in close contact with many harmful substances, it is protected against disease in two main ways. First, it can regenerate itself by repairing or replacing injured tissue. Secondly, the liver has many cells responsible for the same task, what you call redundancy in action. Therefore, if one area is injured, other area will pick up the tab from that region until that region is restored or indefinitely.
Right. So now one unique feature about the liver is the fact that when it is injured, whatever kind of injury that is, whether it is ischemic, whether it is infectious, metabolic, neoplastic even, the response of the liver is going to be in a number of ways that are common to all, causes of injury. Now that makes the differentiation between what caused the injury of the liver is a little bit tricky, because you're going to be having the same kind of result, whatever is the cause. Okay. Now we will be talking about the kinds of responses to injury by the liver cells in this lecture.
So as you can see here, actually from the right diagram right here, the functional unit of the liver is what is known as the hepatic lobule, which is a 3D hexagon that has as its tips the portal triads. You can see this one here and this one here and so on and so forth. Now, in addition to this, in the picture on the right, you will see that between the central region and the portal region is a segment of the liver that is divided into three zones. The three zones are going to be demarcated as the following. Zone 1 is the area surrounding the portal tract, what you call periportal, this region right here, periportal region. The area surrounding the central vein is what you call pericentral region. Between them is zone 2. Now, zone 1 is the area that is mostly supplied with oxygen because it is the nearest to the hepatic artery in the portal tract. Zone 3 is the most distal region from the portal tract, so it is the area that is most likely to suffer as a result of ischemia. Zone 3 is also a region that is very rich in detoxifying enzymes. So in case of a toxin injury, it is going to be the area that we look at under the microscope to see if it has suffered any kind of injury in the process of detoxifying a certain toxin.
All right, the same exact thing right here. So you have the three regions that we have talked about. You have zone 1, and then you have zone 3, which is the central zone, and then zone 2 is the one in between them. Now, a very important actually concept to go over is the concept of the limiting plate. So what is the limiting plate? The limiting plate is the first as you can see in this, with this demarcation, is the first line, the first a group, if you will, or line of hepatic cells, of hepatocytes, what you call actually hepatic cord, the first hepatic cord that separates the portal triad from the lobule, okay? And it is important for the following reason. In the portal triad, there is always an inflammatory infiltrate, a small, very small number of inflammatory cells. What you call actually a standby or a transient inflammatory infiltrate that is present in the portal triad. Now, what's going to happen is that, so there is always actually a question, do you really have a true inflammation of the liver, or is it the transient inflammatory infiltrate that is present in the portal triad that you're seeing in the microscope? Now, if these cells actually cross the limiting plate into the hepatic lobule, then that becomes what you call a true iitis, a true inflammation of the liver. So when those inflammatory cells cross the limiting plate and spill over, the word is spill over into the hepatic lobule, this is what you are going to be calling it as a hepatitis, okay? So it is not there actually. It is in theory, something that, scientists and pathologists construct in order to mark the presence of hepatitis or not. So when it comes actually to inflammation, to the injury patterns of the liver. So basic patterns of hepatic disease, starting with necrosis. So it can be actually massive, it can be in certain zones, or it could be simply, focal, necrosis that is engulfing the liver. Now, degeneration may happen for many reasons. Degeneration may happen as a result, for example, of the accumulation of certain substances in the liver, such as glycogen, such as intermediate filaments of keratin. It could be actually degeneration that is not going to be in the form of ballooning degeneration, which is the two examples that I just gave you, but simply it could be, degeneration that will result in cell death. And that could happen from many causes, including alcohol, that is going to have a toxic effect directly on the hepatocytes. It can be due to, as I mentioned to you, accumulation of certain substances in the liver, certain saccharide, for example, if there is a problem in digesting certain saccharide because of enzyme deficiency, eventually those cells that will accumulate those substances are going to die. Inflammation of the liver could also be divided between portal, lobular, or both, and may involve a combination of the above. Now, what's also important is that, when it comes to the cell of interest, it's going to be different depending on the circumstances. We know now, for example, that alcoholic hepatitis, the cell of interest is going to be a neutrophil, whereas in chronic viral hepatitis, it's going to be actually that of a lymphocyte. We know that, for example, hepatitis A, the cell of interest is going to be a plasma cells, and so on and so forth. Here's an example actually of ballooning hepatocytes, where the cells start to become larger in size, okay, as a result of accumulation of certain substances. Now, another actually pattern, but a smaller, kind of headline, a subheadline, if you will, is the stasis that happen in the liver as a result of liver injury. So because what happened actually between the liver cells, there is the most basic part of the bile tree, the bile canaliculus, plural bile canaliculi, which is what works on propulsion of the bile into the larger bile ducts. So those small biles are going to coalesce, forming the larger bile ducts. Now, what happens actually when there is injury to the hepatocytes, simply, those engines, if you will, between them are going to be affected as well. And as a result of that, there will be stasis, canalicular cholestasis. Okay, now stasis also of the bile could happen from obstruction. In that case, you will not see simply cholestasis, but you will start to see that the bile will spill over into nearby hepatocytes, causing degeneration, causing death by necrosis of those hepatocytes, because the bile is a very corrosive kind of substance. Now, here's acidophilic bodies or consummate bodies. They are simply hepatocytes that got affected by a cause that resulted in them developing apoptosis. So what are the consummate bodies and the acidophilic bodies? They are simply apoptotic hepatocytes. Now, when you start to see a large number of hepatocytes dying, either by necrosis or by apoptosis, the Kupffer cells are going to actually try to chip in, and you will start to see that the support cells, in this case the Kupffer cells, will start to undergo hyperplasia. Okay, in cases of injury to the hepatocytes. Here's another example of this, actually. Bile duct injury. In this case, you will see that it's a smaller one, so you call it a bile ductule. You will see there are a lot of instances where the bile ducts are going to be simply disappearing as a result of the ensuing inflammatory process in the liver. For example, we see it happening in hepatitis C. We also see it in a variety of primary biliary cirrhosis. We see it, for example, in secondary biliary cirrhosis, and we see it also in a primary biliary cirrhosis. You will see that there is what you call ductopenia. So the ducts will start to decrease in number. Now, in addition to this, here you see the lymphoid infiltrate. This lymphoid infiltrate is pretty intense. So when you start to see that the lymphoid infiltrate, especially the chronic cells, in this case lymphocytes, start to form lymphoid follicle, then something that this could suggest to you that this is hepatitis C, because it is one of the features that you see in hepatitis C. Okay. All right.
One of the unique features of the liver is its ability to regrow after extensive insult or injury to it. This regeneration is great, but at the same time, it will result in structural abnormalities. These structural abnormalities will result in further complications for the liver cells. For example, in chronic inflammatory state, as a result of the continuous unabating inflammatory activity that is going on, the liver cells that regrow after their demise will form what is known as a regenerative nodule. If you look into this regenerative nodule, you will see that a very important feature of normal liver structure is missing. And that feature is going to be the fact that instead of seeing a single file of cells, what is known as a single hepatic cord, lined up by hepatic sinusoids from both sides, will not be there anymore. Instead, you will see several layers of these liver cells accumulating in the form of hepatic regenerative nodule. Not only that, we will see that these hepatic cords are going to be lined by a different form of collagen, different from the normal collagen that lines the liver sinusoids. So here we see, as a result of ongoing injury to the liver by alcohol, that there are a group of liver cells that have grown back from stem cells to form what is known as a regenerative nodule. I'm pointing at this regenerative nodule, as you can see here. Now, these regenerative nodules are surrounded by fibrous bands. These fibrous bands are going to obstruct the exchange between the liver cells that are right here in the periphery and the hepatic sinusoids that lines this fibrous bands. The end result is going to be that those liver cells in the periphery of this hepatic regenerative nodule are going eventually to die as a result of inability to reach the nearby blood and nutritional supply in the hepatic sinusoids.
All right, so now actually when it comes to cirrhosis, cirrhosis is, if you want to think about it, it is the final destination of so many different processes that affect the liver. So this could be actually, resulting from ischemic injury. It could be resulting from metabolic injury. It could be resulting from a viral infectious injury. So the end result is going to be, that the liver is going to be turned into a structure that is divided, crisscrossed, if you will, by fibrous septae, resulting in its division into what you call actually into nodules. Each one of those nodules is going to be surrounded from all sides. So the boundary of this nodule will be the fibrous septae. And inside those nodules will be those regenerating group of hepatocytes. Now, those regenerating group of hepatocytes are going to be actually undergoing continuous replication. The reason for this is that they no longer have the structure that I just mentioned to you in the prior slide, in the form of, I apologize, in the prior slide, in the form of a single file hepatic cord. So as a result of that, you will see that those cells are going to actually die because they no longer have access to the hepatic sinusoids. All right. So as a result of that, those cells are going to undergo continuous regeneration, death, and then regeneration. What's going to happen as a result of that, the cell cycle will actually speed up. And as a result of that, there is a chance that, one mutation here and there may actually enter into the hepatocyte, and eventually may be a meaningful mutation, meaning it may result in a malignant transformation of those cells, resulting in the development of hepatocellular carcinoma. Okay, this is one way for hepatocellular carcinoma to result from, cirrhosis and from liver injury in general. All right, so now we'll talk about, where do those actually fibrous strands extend from and to where. We would see that there are those actually that are portal to portal, portal to central, and central to central.
So in this diagram, you will see how cirrhosis comes to happen. So starting with a very extensive inflammatory activity in the portal tract, that would start to get over the limiting plate that we have talked about. So it will cross the limiting plate into the hepatic lobule. And when it does that, it will actually be on its way to go to the next portal tract, what you call bridging necrosis. Why do you call it bridging necrosis? Because those inflammatory cells on their way to the other portal tract will be killing the hepatocyte in the process. So that's why you call it necrosis, because it is resulting in the demise of the hepatocyte in this region. Now, when these inflammatory activity or inflammatory cells reach the second portal tract, that's what you call bridging necrosis. Eventually, those cells are going to be regenerated, and at the same time, you will see that there will be a response from the tissue in the form of fibrosis. There will be fibrosis that is going to replace this bridging necrosis. So the next step is going to be the formation of what you call bridging fibrosis. And as you can see here, it is extending from one portal tract to the other portal tract, resulting eventually in the formation of a nodular structure. Now, the hepatocytes in this region are undergoing a brisk replicative activity as a result of the ongoing inflammation in this region. Now, this replicative activity is going to ensure that the liver cells that died are going to come back, and there will be a regeneration of those cells from the stem cells that are present in this region. Now, the problem, as I mentioned to you, will be that those liver cells will not have the normal architecture of the liver, and they are going to be undergoing replicative activity on a continuous and unabated basis, resulting eventually in the introduction of mutation that may open the door into the development of hepatocellular carcinoma. As you can see here, this is an example of what you call portal to portal fibrosis. Here's an example of portal to central fibrosis, or central, you may see it from central to another central region, central to central fibrosis. In the end stage of the disease, you will not be able to say how the cirrhosis happened. Was it portal to portal, or was it central to central? So in that case, at that stage, actually, everything is going to be mixed up.
All right, here's an example for you just to show you that pathologists do have heart. This is a heart-shaped regenerating nodule, as you can see here. So as I mentioned to you, within this nodule, at least in the early stages of the disease, there is a brisk inflammatory activity going on, and that is going to be accompanied by a brisk regenerating activity happening at the same time. Now, even if the inflammation becomes less as time goes by, you will see that, those cells on the periphery are going to still actually undergo this regenerating activity. Why? Because they are no longer have any kind of actually contact with the hepatic sinusoids. Why? Because there is dense fibrous, bands, fibrous scar that is nearby. The same exact thing happened within the nodule itself, because in the nodule, you no longer have one file hepatic cords. Rather, you have several layers of hepatic cords that is going to do the same exact thing to those peripheral hepatocytes here. So there is a continuous regenerative activity that's going on in the regenerating nodule. So it is good that the liver is able actually to come back from the dead and regenerate those hepatocytes. But the architectural abnormality that will be introduced in this case is going to make sure that this good news is not really long lasting. Why? Because this regenerative activity will be going on, and eventually it may introduce a mutation that will result in the development of hepatocellular carcinoma. The same exact thing right here. So you will see that the relationship now between the peripheral hepatocytes and the hepatic cord. If you remember the normal relationship between the peripheral hepatocytes and between the hepatocytes and the hepatic sinusoids, there is very little tissue that is present between the hepatocytes and the hepatic sinusoids. The hepatocytes do not have a proper basement membrane. Rather, it's a very, very thin layer of type 4 collagen and the stellate cell, interrupted layer of a stellate cell, the I2 cells, that is going to be there. And it is done by design. Why? Because there is a very direct relationship between the hepatocytes and the hepatic sinusoids. The hepatocytes could get actually all their nutrients, all their oxygen from the sinusoids without having any hindrance, without having any obstruction to this. Whereas what you see here actually in the regenerative nodule is that instead of a single file hepatic cord, you start to see many layers of this hepatic cords that is going to make sure that the cells in the middle will no longer have access to the blood, and as a result of that, they will start to die, and then they will regenerate, and it's going to be an ongoing process. Now, some of those cells are going to become binucleated as a result of this process, as a result of the cirrhotic process. And at one point in time, this whole nodule actually may turn malignant. Now,
so we're talking now about portal hypertension. Portal hypertension, by definition, is increased resistance to portal blood flow. This may result from prehepatic causes, intrahepatic causes, and posthepatic causes. The most common cause overall is cirrhosis. Prehepatic causes include obstructive thrombosis. Posthepatic causes include hepatic vein outflow obstruction, such as what you see with Budd-Chiari syndrome. Cirrhosis is the most common cause of portal hypertension and is the dominant hepatic cause. Mechanism of portal hypertension in cirrhosis include increased resistance to portal flow at the level of the sinusoids and an increased pressure of central veins with perivenular fibrosis and expansile parenchymal nodules. So to discuss how portal hypertension is caused by cirrhosis, I would like to show you this diagram here, which comes to you courtesy of, as you can see here, osmosis. So what you have here, you have the perisinusoidal space. This perisinusoidal space that I'm just pointing to now. This space usually is free, is lined up by a very interrupted and thin layer of type 4 collagen in normal circumstances. Interrupted, and that is done by design because you do not want anything to come between the hepatocyte and the blood that is running in the hepatic sinusoids. So in case of any injury that will happen to the liver, whether it is viral, whether it is metabolic, toxin, ischemic, the end result is going to be that this perisinusoidal space that we have just talked about is going to become lined up by a very thick layer of type 1 and type 3 collagen. And instead of an interrupted layer, it will become a continuous layer of these two types of collagen. The end result is going to be the obstruction of those hepatocytes from gaining access to the blood of the hepatic sinusoids. And the result is going to be that these hepatocytes are going to die. So that's the first thing that will happen as a result of cirrhosis. Now, at the same time, these cells that have been laid in the perisinusoidal space are actually have what you call a myofibroblastic ability. So they are able to contract. So not only that you have actually a fibrous tissue that have increased the density of the liver tissue, and by doing this, it will hinder the flow of blood into the liver. But this tissue also has the ability to contract, and as a result of that, that is going to add more actually resistance to the flow of blood into the liver. At the same time, this, as you can see, this fibrous tissue that is accumulating in the perisinusoidal space now is pressuring the sinusoids. So you can tell that this is going to add further actually resistance to the flow of blood into the liver. The end result is going to be portal hypertension, increased pressure in the portal vein for the reasons that we have just discussed.
All right, so now with regard to, sorry about that, regard to hepatocellular carcinoma. Again, one of the ways, I don't know why is that happening? You know, one of the ways for that to happen is if you have this actually brisk regenerative ability, activity of the hepatocytes that may actually introduce a mutation into the equation that will result in making some of those hepatic nodule becoming transformed, becoming malignant. Okay, so and this is what we see actually, as you will see in the next slide, of a hepatocellular carcinoma that is arising in a background of cirrhosis. Now, at the same time, actually, there are other mechanisms for liver cancer to happen. Example of that, what you see, for example, when it comes to the hepatitis B virus, because in hepatitis B, you will see that the genome of the virus is going to become integrated with the genome of the hepatocytes. And that is actually one way for the carcinogenesis that results from hepatocellular carcinoma. As a result of that, there are some who believe that actually hepatitis B virus infection is more carcinogenic than hepatitis C because of that fact, because hepatitis B is able to get integrated within the genome of the hepatocytes, whereas the hepatitis C virus does not do that. Okay, hepatitis C still causes chronic inflammation and causes cirrhosis. Both of them actually may give rise to transformation of those hepatocytes into hepatocellular carcinoma, but it does not get integrated the same way that hepatitis B does. With hepatitis B, there is far more integration, and as a result of that, there is more likelihood of development of liver cancer in those patients with hepatitis B. Now, here is an example actually of a hepatocellular carcinoma that is arising in a background of cirrhosis. Here are examples of that. Here is one of these nodules, two of these nodules. A third of those nodules have become actually transformed. Now, that shows you actually that it is dependent on the mutation that happened to one of those hepatocytes that is undergoing this regenerative activity, eventually giving rise to a tumor nodule. All right, and that's exactly the same thing that you see here. All right, so now hepatic failure. Hepatic failure, if you want to think about it, there are several, syndromes of liver disease that will give rise to, to a presentation. One of them is hepatic failure. In this case, actually, the most common cause is going to be chronic liver disease. Chronic liver disease may actually be, focused on the parenchyma, such as, for example, what you see with the chronic hepatitis, chronic viral hepatitis. It could be focused on the bile ducts, such as what we see, for example, with primary sclerosing cholangitis or primary biliary cirrhosis, or it could be vascular. In this case, you will see it in the form of a process that affects what used to be called the suprahepatic, or what's called now the hepatic vein, such as occlusive disease and the Budd-Chiari syndrome. That's going to reflect back on the liver as a whole. Another actually cause of vascular hepatic failure, example of that is what we find in cardiac cirrhosis. With cardiac cirrhosis, we will see that usually it is a vascular in origin, whether in the great vessels, in the inferior vena cava, or actually in the right side of the heart itself, that the process of cirrhosis may start and may engulf the liver. Okay. Now, there are clinical manifestations for hepatic failure, including the hyperammonia, accumulation of the ammonia in the blood, hypoalbuminemia, because the liver is no longer actually making the protein that's going to result in edema, pulmonary erythema, and spider angiomas. This is actually an ability of the liver to metabolize certain substances, and hyperestrogenemia that's going to lead to hypogonadism and gynecomastia in males. Jaundice and cholestasis, again, it's a factor actually that is going to be affecting the hepatocyte's ability to work on the bile. So in this case, there is going to be retention of the bile and backup of the bile into the blood. And there are causes for the obstruction. It could be an intrahepatic causes, for example, hepatitis. It could be an obstruction that is happening either in the intra or the extrahepatic biliary tree that may actually give rise to the jaundice. Now, hemolytic anemias, are one causes that you guys have studied in the heme block this year. That is going to be, in two forms. There is the hemolytic anemias that may give rise actually to the either, happening either in the vessels, what you call intravascular hemolysis, or actually outside the vessel, extravascular hemolysis in the spleen. At the end of the day, you are actually increasing the amount of the unconjugated bilirubin that you're taking to the liver and increasing the threshold of the conjugation of this substance, resulting in its backing up in the blood and resulting in jaundice. Now, cirrhosis, as I mentioned to you, the three processes that you have seen before. One of them is the death of the hepatocyte that's going to be followed by the regenerative activity of the stem cells that are going to give rise to hepatocytes to take over. Now, one interesting actually fact of this process is the deposition of a special matrix. In this case, we will see that the death of the hepatocytes is going to become actually switching the type of collagen that will get deposited in the hepatic sinusoids in the space of Dicey, in the, just outside the hepatic sinusoids, the space between the hepatocytes and the hepatic sinusoids, is going to switch it from type 4 collagen, which is a very fine type of collagen, to type 1 and 3 collagen. All right, and this type 1 and 3 is a pretty sturdy kind of collagen. So this is, if you want to call it, this is the thick type of collagen that is going to take over in liver cirrhosis, and before that in liver fibrosis. So here are examples actually of the hepatic sinusoids where the venous and the arterial blood mix. And you can see how thin the layer that is dividing them from the hepatocytes. Very, very thin layer, and it is designed that way so that there is direct communication between the hepatocytes that is one cell thick. This is one cell, this is another cell, this is one cell thick of hepatic cords that is surrounded on both sides by the hepatic sinusoids.
So as I mentioned to you in a prior slide, the perisinusoidal space right here between the hepatic cords and the sinusoids is a space that is almost empty, almost free. It is lined up by a very thin layer of interrupted type 4 collagen laid by the itocells, by the quiescent stellate cells known as the itocells. Now that's in normal condition. As a result of the fact that this space is interrupted and free of cells and tissue, there's going to be free movement of nutrients and oxygen between the sinusoids and the hepatic cords. What happens in a pathologic condition is that there are messages that come to the Kupffer cell, which is the command center in this process. This is the Kupffer cell right here, along with the endothelial cells and the hepatic cells. They will receive different kind of messages: ischemic messages, toxic injury messages, infectious messages. The result of this is going to be that the Kupffer cells are going to be making and releasing cytokines that promote proliferation such as the PDGF, the platelet-derived growth factor, and the tumor necrosis factor, which will promote the proliferation of the ito cells, which will switch from producing type 4 collagen to producing type 1 and 3 collagen in higher amounts than normal, resulting in the formation of a continuous layer of fibrous tissue in the perisinusoidal space. At the same time, the Kupffer cell will be also making contraction cytokines such as the endothelin-1 that will promote the contraction of the ito cells, resulting in further hindrance of the flow of blood into the liver. And finally, the Kupffer cells will be making chemotaxis cytokines such as the monocyte chemoattractant protein 1 and the platelet-derived growth factor, which are going to recruit more fibroblasts to the perisinusoidal space. The end result of this is going to be portal hypertension as a result of the contracting fibrous tissue that is now laying the perisinusoidal space, and also the death of the hepatocyte because it will no longer have access to the sinusoids. And as a result of that, it will undergo apoptosis.
All right, so this is simply what we have just talked about, just putting it in words for those of you who like text rather than a picture. Same exact thing here. This is the same picture that we have talked about, the fact that now the space of Dicey between the sinusoid and the hepatocytes, which in normal conditions is interrupted and is free, of interrupted, meaning it's not a continuous layer of ito cells, rather it is interrupted layer that will allow actually for the free exchange of nutrients and oxygen between the hepatocytes and the sinusoids. In abnormal conditions, the Kupffer cells will receive all these messages, will actually start to send and to make certain cytokines that will stimulate the proliferation of these cells, of the ito cells, the making of special form of collagens that will fill now this space of Dicey completely. And that will also induce those ito cells which have myofibroblastic ability to contract. All of this is going to result in increased pressure within the sinusoids, resulting in the portal hypertension that we have talked about.
This is an example of the normal architecture of the liver, where you see that the hepatic cords are lined by this very thin layer, very thin interrupted layer of type 4 collagen. We could see also from this architecture that there are no nodules. There is no nodular architecture in a normal liver. So this is a comparison between a normal liver and a cirrhosis liver. In a normal liver, we see that what lines the hepatic sinusoids are this very thin layer of type 4 collagen. In cirrhotic liver, we could see that inside the regenerative nodule, there are remnants of this type 4 collagen. But the boundary of the nodule is made up of type 3 and type 1 collagen, which is much thicker, much denser, and is the pathologic type of collagen in cirrhotic liver. So this is an example of cardiac cirrhosis. Cardiac cirrhosis results from increased pressure in the central veins of the liver. This increased pressure could result from increased pressure in the right side of the heart as a result of right-sided heart failure, or obliteration of the inferior vena cava, or obliteration of the hepatic veins, such as seen in veno-occlusive disease and Budd-Chiari syndrome. The end result is going to be congestion of those central veins and dilation of those veins. Dilation that will result in atrophy in the hepatocytes surrounding those central veins, resulting in what is known as centrilobular congestion. Now, the second leg of this process will happen when there is a left-sided heart failure that will follow, or a hemodynamic shock, because now the cells that have undergone atrophy will actually undergo necrosis as a result of the fact that they are in zone 3 of the liver, in the pericentral zone of the liver, that is the least oxygenated because it is the most distal from the portal triad. The end result is going to be centrilobular necrosis as a result of the death of those hepatocytes. Centrilobular necrosis will be followed by fibrosis. In this case, the fibrosis is going to start in the central zone of the hepatic lobule and will extend towards other central zones, forming regenerative nodules in the process, what is known as cardiac cirrhosis.
So this is simply again saying what has been said before about the portal hypertension, which is one of the clinical syndrome of liver disease. That liver disease may present with portal hypertension. We did talk about the pre-hepatic causes, the post-hepatic causes, and the hepatic causes. Of course, the most common cause is a hepatic cause, which in this case is going to be cirrhosis. And we have talked about the mechanism of the portal hypertension in cirrhosis in that figure from the osmosis video. Now, we did talk about all of that actually. Now, one thing actually that was not mentioned before is going to be that one more reason for the portal hypertension in cirrhosis is that as a result of this slowness of the circulation towards the liver, there is going to be delay of the clearing of the DNA of the gut bacteria. And as a result of that, this accumulation of the DNA of the gut bacteria is going to result in the release of nitric oxide. And the nitric oxide is going to result in increased hyperdynamic circulation. So there is an added actually component of increased speed of the circulation, or at least an attempt to increase the speed of the portal circulation that is going to compound the portal hypertension mechanisms that we have seen before.
Here's another picture of a normal hepatocyte. Cuboidal cells with a large number of microvilli on the surface to increase the surface area. In addition to this, you see here the smallest functional unit that is working in the propulsion of the bile, also known as the bile canaliculus. So these are the bile canaliculus.
The same exact thing right here. We did talk about this, just to put it in perspective, what you see here. Now you can imagine actually if the liver cell is affected, the bile canaliculus between the two cells are going to be affected as well. So this is why now you are going to be introduced to something known as pattern testing, because a liver disease that affects the parenchyma, sure, the dominant feature, the dominant lab values, if you will, are going to be those enzymes that will come from the liver cells, right? But at the same time, actually, the bile, flow is affected. So we will see that the enzymes that mark the bile flow that actually tell us about the bile flow are going to be affected as well, but not as much as the enzymes that come from the hepatocytes. And the opposite is true as well. So in case of a bile obstruction, we will see that the enzymes, mark the bile flow, that tell us about the condition of the bile flow and the bile ducts, and usually they are present in the bile duct epithelium, are going to be, going through the stratosphere. They will be very high. But at the same time, you have to remember that actually, if any cause of bile obstruction is going to reflect back on the hepatocytes. Why? Because if there is any kind of obstruction, the bile is going to start to accumulate. We will start to see bile lakes that are going to damage those hepatocytes. So in this case, we will see that there is a stark increase in the bile enzymes, but also there is an increase, a more moderate increase in the liver cell enzymes, okay? So it is what's dominant and what follows, if you will. We talked about this as well. Now, actually what you find here is this is something that we're going to be talking about hopefully in the second lecture. So as a result of the fact that you have now actually obstruction to the flow of blood into the liver. So there is also shunting between the portal and the systemic circulation. All of that is going to result in sequestration of the blood in that region of the body. As a result of that, there is actually decreased amount of flow to the kidney. So as a result of that, the GFR is going to be affected and a hepatorenal failure may ensue, or hepatorenal syndrome may happen, okay? Now also, I think there's a better picture of this, but what happened as a result of the fact that, there is a increased pressure in the portal vein, this is going to reflect back on all the tributaries of the portal vein, including actually in the lower esophagus, resulting in the formation of esophageal varices. Also, in the rectal veins, resulting in the formation of hemorrhoids. And it's going to reflect back also into the spleen, resulting in congestive splenomegaly. Now, what happened when splenomegaly happened, the platelets are going to have hard time actually escaping the splenic cords. And as a result of that, there will be entrapment of the platelets in the splenic cord. This is why you will find that in liver diseases, that reflects back on the spleen, liver diseases that result in congestive hepatosplenomegaly, which means, that the spleen will be involved. You will see the spleen becomes a sequester of platelets. So the more severe actually the cirrhosis, the more severe or the more profound the thrombocytopenia. It is one of the indication of the severity of the cirrhosis in a particular patient. Of course, there is going to be, as a result of the increased pressure in the portal circulation, there will be fluid backing up into the abdominal cavity, resulting in ascites. It's more complicated than this. We'll talk about that again in the second lecture. Here's an example of what you're going to be finding actually in portal hypertension, where there is, cirrhosis, a cirrhotic liver that's going to reflect back on everything that is connected to the portal circulation into the spleen, into the lower esophagus and the rectal veins. You will see also, a paraumbilical kind of structure known as palm tree appearance. That's the caput medusa. And we will see also the spider angiomata and the malnutrition. And of course, as a result of the fact that now the liver is no longer being used, to detoxify the blood. Why? Because the blood is being shunted away from the liver and directly into the systemic circulation. Hepatic encephalopathy may ensue. This is a list of the consequences of liver disease. And as you can see, the liver is pretty much everywhere you can think about. Its role in protein building, bilirubin metabolism, fat metabolism, glucose metabolism, coagulation. All the factors, all the coagulation factors are made in the liver. And when it's affected, when it is badly affected, may result in hepatic encephalopathy and also in hepatorenal syndrome. One thing to remember, at least from the American point of view, the liver function tests are 4. Now, if you follow any kinds of other kinds of school of medicine, the British, the French, or the other European, you will see that they sometimes list 6, sometimes they list 8. In the US, it is 4. Each one of them denote a specific function of the liver. So bilirubin is going to look at the conjugation function of the liver. ALT is going to look at the patency of the liver cell. The PT, the prothrombin, is going to look at the coagulation work of the liver, and the albumin is going to look at the protein making ability of the liver. And this is a semi complete list of the hepatic function panel. So from each one of those, one has been chosen. Another point to be made here is to distinguish between liver function test and liver enzymes. They are not the same, okay? So for example, the cholestasis, you have this, that's going to actually denote the condition of the biliary epithelium, versus with the hepatocytes, enzymes, in hepatocytic injury, we will see that the transaminases will be going through the roof. The ALT is going to denote more the viral kind of effects on the hepatocytes more than the AST. The AST is an enzyme that is looked at in cases of alcoholic hepatitis, okay? All right, we'll discuss the second lecture in the next hour or so, inshallah, okay? And if you have any question, you may keep it to that time as well. All right, thank you all.